And now I'm happy to give the floor to Professor Namazova Baranova, who is the first representative today on that very real clinical practice that we are talking from the early morning, because we are going to give the mic to a practitioner, to the great practitioner, academician, and doctor of medical science, professor. And the topic of your presentation is the real-world data in pediatrics. The floor is yours. You're welcome. Good afternoon, distinguished colleagues. Maybe good morning or good evening, depending on your time zone. And first of all, many thanks to the organizers for the invitation and for the opportunity to participate in this very interesting event. Keeping in mind what Professor Kogan said before, we are all working from early morning, and probably we are all a little bit tired. So I will not show any slides today. I will just share my thoughts that probably can be a very good food for the future considerations. So I very briefly describe the current status quo. First of all, we live in the era of evidence-based medicine. Finally, hope we all agree with that the medicine is still science, very logical science that requires particular arguments and evidence. This is not the art, as many other colleagues told us before. So this is still science. And in this evidence-based medicine, in all these constructions, what is very important is the search of evidence, evidence of different origin. That is extremely important. Why? Because today we listened to a brilliant presentation of Professor Plavinsky about the clinical trials, about the history, retrospective analysis. But, from that thalidomide catastrophe, it became very clear that probably the most important that we should look at and think of if we speak about such patient like a child, vulnerable patients, is safety. Safety first. That's the most important. And correspondingly, any poorly conducted clinical trial is, first of all, a big challenge for the patient. And this is very clear that the patient could be misled by the poor quality data. It can be a challenge for the treating doctor because it could be unjustified decision. But it's also another challenge because in our country, as we all know, we don't have insurance of medical liability. No insurance of medical liability. That makes us very vulnerable in different situations. And such situations could be found in the life of everyone when one of the doctors is using particular treatment or diagnostic intervention, and then patient is worsening, and maybe patient even died, and then there is a court case, and we cannot help the colleague because that intervention is not guided anywhere in the documents that we could present as an argument that the treatment was carried out according to the standards. The data of the clinical trial is just only one part, as it was shown by our previous speakers from Roche. But the other challenge is a real clinical practice that is around us daily. And we are all part of that. And here, probably the biggest question is, can we now freely discuss the issues of the real clinical practice if until now we have not yet resolved the issues of the evidence-based clinical practice, the results of RCTs? What I mean by that, when from the beginning of 2000 we realized that we need to select arguments, that we need to carry out clinical trials, specifically in our legislation, we faced the fact that there are no drugs for children, and there will be no in the future, by a very simple reason, because there is no stimulating type of the legislation that would recommend the manufacturers, first of all, think about the drugs they produce would be similarly accessible both to the adult and to the pediatric population. That means the whole world, like United States or European countries, Japan, etc., back in 2007, when they adopted these laws, they already switched to this stimulating legislation. And due to this approach, we have at the end a number of products simultaneously for adults and for children, because clinical trials were carried out also for pediatric population as well. Then European Congress of Pediatricians in 2009, we heard first presentations about the representatives of EMER, European Medical Agency, and representatives of the European professional community that were very happy that finally children that they have similar to adults access to the effective and safe drugs. And the data about the efficacy and safety were received in RCT. But unfortunately, regardless all our efforts, our pediatric community here in Russia and those who supported us for the next 13 years until now, we don't see any dramatic changes. And up to now, our legal documents are still the same. So correspondingly, for those clinical guidelines that are a must to do, we still face the difficulty to selecting arguments because clinical trials with pediatric populations almost not carried out. Maybe some of you will tell me, okay, stop talking about clinical trials. Let's go to the real world data. All right, what about real world data? Let's have a look. The data on pediatric population is almost absent, and it's very difficult to write clinical guidelines. And also, there is a problem with implementation of the guidelines into real practice, because when we perform audits of the medical care in the different regions of the country, we are facing the same approach, the same pattern. In fact, clinical guidelines are not carried out properly. So we invented the index of hazard to the child, and this is the unjustified hospitalization, unjustified pain when something is done to the child, injectables, when the same could be given per os. And correspondingly, polypragmasia, so multiple drugs. So these indexes during our first visits sometimes reach 50 units, 50%. That means huge, huge parameters. But if we explain, if we again return them back to the clinical guidelines, slowly, steadily, we come to the normal clinical practice. But it takes time, and these are multiple trainings. So to say roughly that absolutely everyone in the country is ready to the adequate perception of something which is called real world data, far from it. In the country, there is prevailing approach of so-called scientific schools. And I would present it with the following explanation. Evidence-based medicine, EBM, which is our basic concept to work currently in the real clinical practice, transformed to the position-based medicine or meaning-based medicine. And this is not exactly what we wanted. Because if you enter any hospital or any clinic, almost in 100% of the cases in children, you will see a very nice picture in the frame on the wall, and they offer you what should be in the nebulizer. And if you read this list, you will surprisingly find there that almost all these solutions cannot be applicable through the nebulizer, but still it is recommended. It is widely recommended. Moreover, if you look at the PhD studies which are carried out, they're also not perfect, and working for many years in all Russian certification commissions, sometimes I'm really in despair because normally the title is not reflecting the meaning is not reflecting the group, and those group which are recruited, they cannot answer the task, so they cannot find the argument. So the main question is, if such PhD study, if I refuse it, and if then it goes into the clinical practice, definitely not, because it is simply hazardous to the patients. And there is another topic, which is called registry, very nice words. And this is very perspective. We, as pediatric community, are trying to be on time, and we have several registries in the Pediatric Union of Russia, but still we have lots of questions. There is no legal status of these information systems. There is no financing to them, although the data we are collecting is incredibly valuable. And together with Aston Health, for example, we created a registry on severe asthma in adults and pediatrics who are getting immunobiological treatments. We analyzed it and we proved very clearly that children as patients are dramatically different from adult patients. with the same severe asthma that requires biological treatments. So the information that we can get from the registry cannot be overestimated. But the same like with clinical trials, we still have no particular legal definitions, legal acts, normative documents. Besides, there are alternative registries from the Ministry of Health, and they are not actually registries. They are just lists on how to use these or those drugs. Additionally, related to this topic, the use of medical records, as we call it, electronic medical records, probably as children. This is reflex of what we are doing. Particularly, we have some designs when with two interface, this is information system, one for the doctor and one for the patient, allows to control online and communication is facilitated. Whatever nosology we are taking, we always face the same. While the patient was in the acute period, while the patient has problem, they will be actively communicating with the doctor. But as soon as patient goes to remission, then compliance dramatically reducing, and then finally, all these tools definitely should be considered from the point of increasing compliance. But for that, you need really very big information support. And another important argument, which has not yet been provided, but it seems to me very serious because it's again somehow underestimated in our routine life. Because in our country, the system of the healthcare, and I'm speaking about the pediatric healthcare, is totally different versus other countries. And if we are offered the models which are prevalent, no matter any systemic approaches which are prevalent and they're applicable in the UK or in the United States, in the countries where initially the system is based on the patient observation by the pediatrician, then to us, this systemic approach may not be applicable because our system of the healthcare is totally different. So wrapping up my short speech, I would like to go back from what I've started. If we speak about relations, the data of RCT and RWD, real world data, how these relations should look like in between. So these are two bricks. These are two bricks that create the same platform for decision making. This is the data of the clinical trials as the basis, and then real world data as a building on top. And again, it should be clinical decision making, or maybe it can be the other situation when on the other side, we have the data of the clinical trial, and on the other part of the scales, the real world data, because sometimes they're contradictory. And it has some particular explanations. It is very clear that in the world, in the real world, we never have ideal patients like in the clinical trials. And if so, then how we should make decision in between these two parts and how we should look for the correct ratio of arguments for the further decision making. So this is how I want to finish my presentation with this question, again, trying to draw your attention to one important topic. So although that everybody accepts in the modern medicine the concept of programming health programming for about 1,000 days from birth, 9 months of pregnancy, and then up to 2 years of infancy. So regardless the understanding that all diseases come from the childhood, pediatricians are always last to speak at any conference. And definitely, this is a very big systemic bias, very big systemic error. And I would like to draw your attention to this error as well. Thank you very much for the microphone. Thank you very much, Professor Namazova-Baranova, for brilliant presentation. Well, the only thing what I want to add that our conference is not coming to an end. Well, it is difficult to say that we were at the beginning of the conference. So the next conference, which we are scheduling for the near future, will be launched by you, I promise. Thank you very much. Thank you very much.